Okay, thanks very much for inviting me. My name is Viyaasan Mahalingasivam. I'm a kidney specialist based in East London at Barts Health NHS Trust. I'm also nearing completion of a PhD at London School of Hygiene and Tropical Medicine, supervised by Professor Laurie Tomlinson. I've been part of the OpenSAFELY team for around 3.5 years, working on a few projects related to COVID-19 and kidney disease, and today I'll be presenting some work on long-term kidney outcomes as a consequence of COVID infection. So sadly, this is a rare example of an OpenSAFELY project that was rejected by the BMJ just a couple of weeks ago, but we got some constructive peer review feedback, so we'll redirect it elsewhere. So some of you may remember reports from early on in the pandemic about shortages of dialysis equipment in several cities around the world. So dialysis is a treatment for severe kidney injury. And indeed, after the lungs, the kidneys were the second most commonly affected organ in people who had severe COVID infection that needed hospitalisation. The exact mechanisms for this remain largely unknown, but it's likely multifactorial related to the virus itself and also the inflammatory response. But certainly at the peak of the pandemic, hospitals were seeing an unmanageable number of people requiring dialysis in the intensive care setting, and certainly not least in London where I was working. So because of this, we became concerned about the potential longer-term impacts of COVID on kidney function amongst survivors and the longer-term burden that kidney disease would pose across the country. And this included potentially any sort of lingering effects in people with milder COVID infections as well. And so we used the OpenSAFELY platform to try and investigate this potential burden. And the reason for this was that the OpenSAFELY platform provides a representative representation of the country, so it could help inform policy making, but also that we would be able to look at kidney failure, which is a relatively rare outcome with a good amount of statistical power. So we selected people with COVID from national testing data, primary care codes, and hospital codes, restricting to those who'd survived 28 days. We then followed people up from the start of the pandemic up until the end of 2022. And the people with COVID here, you'll be able to see are represented by the yellow counters. We matched each person with COVID to 3 others of the same age, sex, and region, represented here by the green counters. And we excluded people with pre-existing kidney failure, that is, people who were on dialysis already or had had a kidney transplant at the time of their COVID infection. We then categorised people based on whether or not they were hospitalised for COVID, shown here by red counters for people who were hospitalised. And we used a dynamic approach, so matches who developed COVID over the course of follow-up would then move into the COVID group, and then they themselves would be matched to 3 others from the primary care population of same age, sex, and from the same region. Our primary outcome was kidney failure, so that's incident need for dialysis, kidney transplant, or if their kidney function had dropped below 15%. And our secondary outcomes were a halving of kidney function from baseline or death, which is an important competing outcome. We used stratified Cox proportional hazards models adjusted for an extensive range of potential confounders that we were able to extract from OpenSAFELY, including socio-demographic variables such as ethnicity and deprivation, concurrent medical problems, including baseline kidney function, COVID-19 vaccination status, and wave. We selected 3.5 million people with COVID who were matched to 10 million from the primary care population, and the groups were broadly similar in the distribution of baseline characteristics. I think I've skipped ahead. I think I've lost a slide there, but that's fine. I'll just walk you through. So this particular plot is shows you on the top row people who are hospitalised for COVID compared to the matched population. Sorry, people who are not hospitalised for COVID compared to the matched population. And on the bottom row is people who were hospitalised. And the red dots are the overall hazard ratio over the course of the study follow-up, while the sort of purple, blue and greyish dots are period-specific hazard ratios. So the starting from 0 to 29 days, then 30 to 89 days, then 90 to 179 days, and then beyond 180 days. And as you can see, when we look at this by hospitalisation, there was no increase in kidney outcomes in people who were not hospitalised compared to the matched cohort. And interestingly, this finding was in contrast to results from earlier in the pandemic that had been published from US veteran data. However, we did see a marked increase in kidney outcomes in those who were hospitalised, and that risk persisted beyond 180 days. And in addition to this main analysis, we carried out a sensitivity analysis where we matched people with COVID to a historical cohort from before the pandemic in 2017 to 2019. And this is to address exactly the point that Emily raised about potential misclassification. So where people had COVID in the matched group but hadn't been coded as such, perhaps due to a lack of testing or because they had mild infection that didn't warrant notification. However, when we did this analysis, we saw very little difference compared to our main analysis. When we looked by COVID wave amongst people who were hospitalised in COVID-19, shown here in the blue dots, there was no decrease in risk as the pandemic progressed. So if you look at the top of the plot, you've got the first wave, so between February 2020 and August 2020. And at the bottom is the more recent wave from December 21 to December 2022, when the Omicron variant was dominant. And the hazard ratios remained elevated across the period amongst people who were hospitalised. And lastly, we looked at ethnicity as a potential interaction, and we found quite alarming ethnic differences in outcomes. So on this plot, you can see the black ethnic group in blue, the South Asian ethnic group in purple, and the white ethnic group in yellow. And as you can see overall, people from a black ethnic group had 5 times greater risk of kidney failure after COVID compared to people without COVID, with 2.5 times increased risk in the South Asian ethnic group and 2 times risk in the white ethnic group. Again, this seems to have been driven by people who are severely unwell, requiring hospitalisation. So to conclude, we found an increase in long-term kidney outcomes after COVID. This appears to have been driven by people who are sick enough with COVID to require hospitalisation, but we didn't see any increase in risk amongst those who are not hospitalised. There was a notable increase in hazards in people from black ethnic groups, and amongst people who were hospitalised, the hazard ratios for kidney failure remained high in the latter stages of the pandemic as they did in the earlier stages. So I'd like to thank my colleagues and supervisors in the OpenSAFELY team from across LSHTM and Oxford, and in particular our patient and public involvement co-producers as well. Thank you very much.